Hello, I'm Jan Basile, and I'm speaking with Dr. Steve Daniels about alarming health issues which have reached epidemic proportions in our nation's children and adolescents. They are obesity, dyslipidemia, and hypertension. Steve, how big a concern is obesity in childhood?
Well, it's actually becoming quite an important concern. In the last 15 to 20 years, the prevalence of obesity has tripled. It's gone from about 5% up to over 15%, around 16 or 17%, with some ethnic groups and gender groups actually having a higher prevalence than even that. But along with the increase in prevalence, we're also seeing an increase in severity. And so we're now seeing adolescents with BMIs of 40 and 45 and 50 and 55. And with all the comorbid events that go with that.
Wow. And with that obesity epidemic in children and adolescents, are you seeing more hypertension and dyslipidemia?
So it's interesting. We are definitely seeing more hypertension. The question about dyslipidemia is a little more complex and depends on some issues of definition and that sort of thing. But in the hypertension arena, if you compare national surveys over time, the average level of blood pressure is going up in children and adolescents, and that's resulting in an increased prevalence of hypertension. So again, if we went back 20 years ago, we would have said that the prevalence of hypertension in children and adolescents would be about 1 or 1.5%. More recent data suggests that it's as high as 4, 4.5, in some cases even 5%. So pediatricians have tended to think that hypertension is a relatively rare event, which is obviously very different than the situation in adults where it's viewed as one of the more common medical issues. I think pediatricians are going to have to change the way they look at this and actually see hypertension much more the way an internist would see it, that it's actually a relatively common abnormality.
So when you see a young person with hypertension, is it usually from a secondary cause, or is it essential, as we talk about in the adult?
Well, again, the historical wisdom was that it was usually secondary, and that turns out to be completely wrong. So actually, the more common cause of hypertension now is essential or primary hypertension. It depends a little bit on the patient profile. So if you have a very young patient, and you have a patient with a very high blood pressure, and also if you have a patient that doesn't have much in the way of family history, that's a patient where you really ought to think through, could this be a secondary kind of hypertension? But for the older patient with stage 1 hypertension, with some obesity to go along with it, with a family history of hypertension, that's almost always going to be primary hypertension.
Interesting. Let's just go back a little and talk about the diagnosis of hypertension, because I think a lot of physicians are still unclear about how we make that diagnosis.
Well, the first issue is we have to measure it correctly, and there's obviously a lot of attention to detail that goes into that. When you have the correct measurement, then the question is how do you classify that measurement in terms of our scale? And so we think of normal blood pressure as being below the 90th percentile. We think of pre-hypertension as being in that 90 to 95th percentile range, and then hypertension above the 95th percentile. But to be considered hypertensive, it has to be persistent. So you really need 3 hypertensive readings over 3 separate visits. And then we actually have stage 1 and stage 2 hypertension. Stage 2 hypertension being that level of hypertension at which we really need a more immediate workup. And that's at the 99th percentile plus 5 millimeters of mercury, which ends up being about 12 millimeters of mercury above the 95th percentile.
And your workup in the pediatric hypertensive community is a little different than our baseline workup, isn't it?
Yeah, I suppose it is. So one of the things that we do as a routine is even though renal disease may be uncommon, we do BUN, creatinine urinalysis, looking for potential renal abnormalities. the workup focused on secondary hypertension actually it really depends as much on the history and physical examination, which is probably not so different than the adult with hypertension.
But just for instance, is LVH a target? So are you doing an echo?
Yeah, so one of the things we've become very concerned about, and one of the ways that really helps us understand whether hypertension is having an adverse effect or not, is what are the downstream effects. And what we found is that left ventricular hypertrophy, which is best determined by echocardiography, is really our best marker for a cardiovascular impact of hypertension. And in fact, it turns out that in children with hypertension, left ventricular hypertrophy is relatively common, and actually even fairly severe left ventricular hypertrophy, a level at which would increase risk in an adult for cardiovascular disease, you can see in adolescents with hypertension.
Yeah, that's the interesting difference. In adult medicine, we do an EKG, but can't get reimbursement for an echocardiogram unless we have that there's a murmur or some other reason, a downstream effect. In the pediatric community, you get reimbursed for that echo.
We do, and there's also pretty substantial evidence that the EKG is really not either specific or sensitive for left ventricular hypertrophy in children. So it's actually, we really need the echocardiogram to be able to get an accurate determination of the left ventricular mass.
Okay, and then let me just shift to the treatment of both hypertension and dyslipidemia. And I don't want to minimize lifestyle and the importance of lifestyle, but for the sake of time, I do want to talk about drug therapy, because these drugs are now trickling down to the pediatric community, and a lot of internists are seeing adolescents, and we're sharing some of these patients. So tell us just a little bit about the drugs you feel comfortable using for hypertension after lifestyle fails, and the lipid-lowering drugs that you feel comfortable using.
Well, so we really are handicapped in a way in pediatrics, because we have nowhere near the database that you have in internal medicine about safety, efficacy, and especially about comparisons where we could compare one drug to another. And that's true in hypertension and in dyslipidemia. In hypertension, we have started to have some clinical trials. So we have short-term data on safety and efficacy. And we know that drugs from the usual classes that are used in adults can be used safely and effectively in children. What we don't know is what's the best drug class to start with, because we don't have studies that really give us that kind of information. Hopefully we will in the future. So in a way, that leaves the pediatric specialist with a kind of a range of drugs that they could choose as a first-line drug. The approach to treatment, though, is actually very similar. So you pick a drug or you pick a class, and you start at a relatively low dose and work your way up. You may also need to add second and occasionally third drugs to that mix. What we haven't established as well in pediatrics is whether these fixed combination drugs are really an appropriate way to manage hypertension in children or not, but I expect that we'll be using them more as we get more experience with them. Yeah. On the dyslipidemia front, again, the drugs that are available for adults are the drugs that we have available for children. Again, our database is less robust, but we have now a many-year history of using both bile acid sequestrants and statins in children, and I think we can say pretty comfortably that they have the same kind of safety and efficacy profile that they have in adults. The good news is often we're able to use lower doses in children, and we know that with statins, for example, the prevalence of side effects would go up with a higher dose. So that's an advantage of dealing with kids.
Very good. Well, I want to thank you very much for being with us, and I want to thank you all for being with us at the annual meeting of the Southern Medical Association.